Hello people, let us look at complications of hernia. So what happens if you don't treat the hernia, right? So basically initially if this is the sac and the contents are coming here, initially when you press you can reduce it, right? Or when you lie down it will go down, right? Only when you stand up probably it will pop out. So basically initially it will be reducible. But what will happen as time progresses, there can be adhesions, right? So there will be irreducibility. It will not reduce in size, isn't it? So let us look at that here. So it will become irreducible. That's what they're trying to say here, isn't it? So due to adhesions formed between the omentum sac and the contents, there can be irreducibility. So irreducibility produces dull aching pain. You can see here, guys, initially it is reducible because it doesn't have adhesions. Then here you can see adhesions. So when there are adhesions, what will happen? The content, which could be omentum or the bowel or whatever, there could because of adhesions it will not reduce in size. Okay, finally here they are showing something that is strangulated kind of a thing, right? Here showing strangulated hernia. Initially it will be obstructed, okay, then it will go to strangulation. So you have reducible, irreducible, obstructed, strangulated. So when it is irreducible, the hernia is tense, it's tender. Irreducible, there is no impulse on cough because of adhesions, it doesn't come in or out, right? It is stuck there. A recent increase in size of swelling could be there. Okay, that is irreducible. Then what happens? It goes to obstructed. Irreducible hernia plus obstruction to the lumen of the gut gives rise to obstructed hernia. So what happens? Let us look at a photo for obstructed. Look at this obstructed hernia. You can see it is kind of there is obstruction to the lumen of the bowel. Is that what they are saying? Obstruction to the lumen of the gut gives rise to obstructed hernia. Here there is no problem with the blood supply to this part of the bowel, looks like. Okay. It produces colicky abdominal pain, abdominal distension, vomiting and stepladder peristalsis. Stepladder peristalsis. Some movement of the bowel looks like it is affected. Okay. What are the factors responsible for the obstructed hernia? A narrow neck, which is very clearly visible here. It is a narrow neck. So there are adhesions. So it will be irreducible. Then it becomes a narrow neck. Sudden straining can cause this obstructed hernia. Too many contents can cause obstructed hernia. Long duration of hernia can cause the obstructed hernia, and sliding hernia also. What is sliding hernia? Here they are talking about the sigmoid colon. Okay. The cecum, the sigmoid colon. Slipping of the posterior peritoneum along with the retroperitoneal viscus. Okay. So something they are talking about the cecum being on the right side. If it is on the right side, but leave this. Usually it will be on the left side. It will be the sigmoid colon. Okay. Here they are showing the sliding hernia, the urinary bladder, part of the urinary bladder they are showing here. One more sliding hernia they have shown here. What exactly is this? What is this content which is there inside? So guys, what were we actually looking at? We were looking at the factors responsible for the obstructed hernia. Now let's move on. How will you treat obstructed hernia? Urgent division of the neck of the sac followed by herniorrhaphy or hernioplasty. So that neck, right, whatever the neck has formed, they want to divide this neck. Okay, then they will do the standard hernioplasty, herniorrhaphy. Okay, now let's move on to the next problem, that is the strangulated hernia. So what happened? First it was reducible, then it became irreducible because of adhesions, then it became obstructed, now it's becoming strangulated. Obstructed did not have any problem with the vascularity. There was a neck, right? Some stepladder peristalsis, etc., etc. They said. Now we are talking about strangulated hernia. What is the strangulated hernia? Look at the color itself. It will tell you something is wrong here majorly. So in strangulated hernia, irreducibility is there, obstruction is there, and there's impairment of blood supply to the intestine. So this is the extra thing here. Impairment of the blood supply will be there. Okay. So what did you understand here? So strangulated hernia is nothing but the obstructed hernia, which then becomes, there is impairment of the blood supply. Okay. That is strangulated hernia. Look at the pathology if you're interested. Then there will be some gangrene at the constriction ring first. Then they contain decomposed blood. Gram-negative organisms will start multiplying. There will be endotoxic shock, endotoxins, because it's gram-negative, isn't it? Then, so who is going to constrict? Usually the deep ring or the external ring are the common constriction agents. So this is the deep ring and this is the external ring. These are the ones that will actually constrict. When they constrict, what will happen? There will be blood supply will be hampered and there will be strangulated hernia. Okay, so what are we looking at in this video? Complications of hernia, usually the inguinal hernia, let us say. So what will be the clinical features, guys? In this case, what will be the clinical features of a strangulated hernia? So there will be a sudden severe prolonged pain. Yes, prolonged pain, severe pain. Clinical examination, what will you see, guys? The color itself could be some bluish, is it? It will be very tense, okay? Tender, no impulse on cough, because obviously it has come via the adhesions, etc., right? Irreducible, obviously. Recent increase in the size, yes, because of this is the same thing that you saw in irreducible, because of all these adhesions, okay? Then general condition of the patient is poor. He'll have hypotension, rebound tenderness, rigidity. He will be guarding, right? He will try to guard so that you don't hurt him. Absent bowel sounds, let's mark this, and a toxic look. Now, how will you treat a strangulated hernia? So the patient you will hospitalize, you will give a Ryle's tube to prevent vomiting, to prevent abdominal distension. What is this? Nasogastric tube, isn't it? How's it going, people? Actually, in this video, we're looking at the complications of hernia. We are focusing more on the inguinal hernia. This is a strangulated hernia with gangrene. Here they are showing the bowel. Here there is the omentum. So the content of an hernia could be what? It could be the bowel or the omentum. So here at the ring itself, the first gangrene is appearing here, right? It's appearing proximally first, and then it progresses. Then let's look at this. Intravenous fluids, where were we? We were looking at the treatment. Okay, sorry guys, we're looking at the treatment. Let's just look at the treatment from the beginning again. To hospitalize the patient, give a Ryle's tube, that is nasogastric tube, to prevent vomiting and to decompress the stomach, reduce abdominal distension. Remember, here we are talking about the strangulated hernia, right? So you will give IV to correct the dehydration, to prevent renal failure. You will give analgesics which are narcotic. You're not giving the normal NSAIDs. You're giving the narcotic analgesics to reduce the pain. Attempt should be made to reduce the swelling if there is no gangrene, right? When there's no gangrene, you will try to reduce the swelling. How? By you have to sedate the patient first. You will flex the patient's thigh, and then you'll adduct and medially rotate. What are they doing? Medially rotate. Okay, then with the right hand, the sac is gently squeezed by applying pressure. At the same time, with the left hand, the proximal part of the sac is guided into the inguinal canal. This procedure is called as taxis. This you will not do if there is gangrene. Remember, you will do all this taxis to reduce the strangulated hernia. Did it make any sense at all, people? What are we looking at? Strangulated hernia. What are they talking about? Something called as taxis. If there is no gangrene, you will try to reduce the hernia. Complications of forced reductions. They're telling you if you forced reduction, if you try to do this, what you may do. You should be careful. You should not do if there's gangrene. And then you will prepare the patient for surgery and blood. You will group the blood and cross-match. You'll keep the blood ready, basically. What is the surgery for strangulated hernia, guys? Very important here. Look at this. It's not your standard hernioplasty, herniorrhaphy. Don't write that. There is some specific thing here. What they told you is there is constriction ring here. There is gangrene, which is all over now, let us say. And there is gram-negative bacteria here, endotoxins. There could be endotoxic shock or something. So what they want to do is they want you to first, remove all this dirty thing. So don't bother about this. Let this be tight. Don't bother about this ring. Let it be tight. Remove all the content here, which is very dangerous, all this. Then we will come to the ring. This ring, don't touch first. Okay. So look at the explanation here. The constriction ring should not be divided. First, all the toxic fluid from the sac is aspired. The constriction is then divided. So you're going to the ring later after removing the toxic fluid. Okay. Then what else saying? How to divide. Don't hurt any vessels or inferior epigastric vessels and all. Don't damage them. If the bowel is gangrenous, then what will you do? You will remove that part of the bowel, whichever is gangrenous. Resect the gangrenous segment and anastomosis is done. So whatever is there, they're removing it and they're doing some anastomosis, looks like. Okay. So if it is gangrenous only, they're trying to remove all that gangrenous segment. Okay. If the viability of the bowel is doubtful, if you're not sure, then what are they doing? They're covering it with hot wet mops and they're checking if it will return to pink color. They're checking. They indicate viability. How to check whether it is viable or not? If you're not sure whether it is gangrenous, if you have to remove it, they have some tests there that you can do. Okay. Hot wet mops. What shall we call this test as? Hot wet mop test? No, sure, they didn't give a name. If the general condition of the patient permits, repair of the hernia may be done. Okay. So how will you repair the hernia? You will use the what is this? That biological mesh they want to use here. Okay. They don't want to use the synthetic mesh and all here, okay, because there's already infection kind of a thing, right? So if you use synthetic mesh and all, there can be more infection, looks like. So they don't want to use all that here, looks like. Then what is this? If there is peritonitis, evidence of peritonitis, you can do laparotomy, okay. Look at this box here, surgery for strangulation. For strangulation, what will you do? You will do an inguinal incision. You will identify the sac. First, you will aspirate the toxic fluid. Then you will divide the constricting neck, that constricting ring. Then you will check the bowel for viability. Then you will resect the gangrene. You will repair the hernia. Broad spectrum antibiotics you have to give here. They're very scared of infection here. They don't want you to touch the ring first, and they want you to remove the toxic fluid first. They want you to check for the viability. They want you to remove the gangrenous segment. You want to repair the hernia with some biological mesh they want to do. They don't want to put synthetic mesh because of all this infection, and they want you to give antibiotics. See guys, there can be strangulation without obstruction also. That is also possible, okay. So when did they talk about strangulation? Say whenever there's bowel, they seem to be more concerned about strangulation, isn't it? But if it is omentum or omentocele, they're thinking that there's strangulation without obstruction. Without obstruction, there can be strangulation, okay. Richter's hernia, Litter's hernia. What are all these? Omentocele, omentum will be there. Richter's hernia, what will be there? Portion of the bowel wall. Only portion of the bowel wall is herniated. And Litter's, right? L-I-T-T. Isn't that L-I-T-T? Yeah. Litter's hernia, they're talking about Meckel's diverticulum. Let us look at these. Look at this one, guys. This photo here, Richter's hernia. You can see only one side is inside the sac, not the other side. So this is a partial kind of thing. In this, there will be no obstruction, but there can be strangulation. You can see this part is strangulated and the bowel is not obstructed also. Okay, this kind of makes sense to me now. Very good. See, this is Litter's hernia. They're talking about the Meckel's diverticulum, which has got herniated, looks like. Yeah, that's what they have written here. Litter's hernia. So basically in this, what will happen? There will be no obstruction, but there can be strangulation. Guys, did you understand the concept? So guys, let us continue. We have reached here. See, it was reducible, then it became irreducible, then it became, what did I say? Obstructed, then strangulated. Sometimes you can have strangulation without obstruction. Okay. Then there can be, there's one more kind here. What did we say? Reducible, irreducible, obstructed, strangulated. See, obstructed, if it is obstructed because of fecal matter, they are calling it as an incarcerated hernia. Looks like the content of the bowel has come out. See, obstruction caused by fecal matter. This can happen in sliding hernia, where you saw that cecum, sigmoid colon and all that, right? So incarcerated hernia will be where the fecal matter is causing the obstruction. That is incarcerated hernia. There's just one more type of complication, guys. That is the inflamed hernia. Let us look at this. So inflamed is when the contents of the hernia get inflamed, like the appendicitis, which is inside the hernial sac, Meckel's diverticulitis, which is in the hernial sac. So all that, if it gets inflamed, it can become inflamed hernia. So the complications of hernia can be dangerous. So it can raise, what and all can be there. It can be a simple obstruction to a life-threatening strangulation can happen. Usually, guys, in this inguinal hernia or an indirect hernia, it is coming through a narrow path. So the chances of obstruction strangulation are more. Okay, but when it's a direct hernia, the defect can be big. So strangulation obstruction will not be there much in a direct hernia, but still it can happen. So when it comes to an inguinal hernia or a indirect hernia, the chances of obstruction, strangulation and all are more. Okay, so you should be careful and handle the hernia. Okay. So here they have a summary of the complications of hernia: irreducibility, obstruction, strangulation, incarcerated and inflamed. Okay, these are the complications of hernia. That's it, guys. In this video, you looked at the complications of hernia. Bye-bye.